It seems that the epidemiology of the PIMS, or this new disease that we're seeing, is a little bit different than from the Kawasaki. So, for example, one thing that is quite striking and interesting is that this increase in cases has not been reported in Asia. It's been reported in France, in UK, and now here we think we're starting to see those cases, but not in Asia.
That's Dr. Marie-Paule Morin, a pediatric rheumatologist at St. Justine University Hospital in Montreal. She's a clinical assistant professor at Montreal University. She's our guest on this special COVID-19 series of Around the Rheum, the Canadian Rheumatology podcast. I'm Daniel Ennis. In Canada and around the world, the numbers of cases and deaths caused by the COVID-19 pandemic is continuing to rise. Among the confirmed cases, only around 6% have been recorded in patients under 19 years old. Pediatric patients were not, initially, felt to be the main target of the virus. However, a correspondence published in The Lancet on May 6th outlined a hyperinflammatory shock syndrome in 8 children in the UK felt to be related to the virus. Since then, more reports have been published describing unusual pediatric syndromes potentially linked to the virus. Symptoms very similar to Kawasaki disease have also been reported. Dozens of cases like this have emerged in Toronto and Montreal and elsewhere. For more on this evolving issue, let's go to Dr. Marie-Paule Morin. Marie-Paule, welcome.
Thank you. Thanks for inviting me.
Our pleasure. So, to begin, can you give us a description of the sorts of symptoms that these patients are actually experiencing?
So it's quite there's a continuum of symptoms they can experience. Some of those patients, they look more like Kawasaki disease. So Kawasaki disease is a fever for more than 5 days, and with kids who have like a rash, and they can have conjunctivitis, they can have adenopathy, they can have involvement of the mouth with cracked lips, and they can have also symptoms with the hands and feet, so swollen or rash. So a certain proportion of the kids that we're seeing fulfill the criteria for Kawasaki disease, either completely or just partially. Some of the kids, they look more like toxic shock syndrome, so really with hypotension, they can have a rash too, and a multisystemic involvement. And on the other end of the continuum, I could say some of the kids look more like really a hyper-inflammatory syndrome with really, again, either cardiac involvement and very, very high inflammatory markers. So those would be mainly the different symptoms that we can see. So
you've described kind of 3 somewhat distinct but overlapping subtypes.
Yes.
And how is it established that these are associated with COVID in particular, if you see these in pediatric patients anyways?
We suspect it's post-infectious inflammatory symptoms because there's a clear temporal association of those cases with the COVID-19 pandemic. So, for example, in the first countries who reported those cases, or an increase in patients with this, we call them pediatric inflammatory multisystem syndrome, or PIMS. And so this encompasses the different clinical presentation I discuss. And so the temporal association has been noted in countries like France or UK. But for example, in France, they had a peak of the number of those cases or those kids admitted to a hospital about 4 weeks after the peak of the COVID epidemic. And that's more or less what we are seeing here too. So a little bit after the peak of the pandemic. We're not sure if there's a causal relationship, and so that's to be studied. But as I said, we think it's more likely to be like a post-infection inflammatory syndrome, also because most of those kids don't have positive PCR, so there's no evidence of active viral replication. But a lot of those kids have positive IgG antibodies, which are suggestive of a previous infection. So those are the main hypotheses for the moment.
I think that's interesting that you point that out. That initial Lancet paper On my read, initially all 8 patients were negative, and then in follow-up, as per the paper, only 2 were positive by PCR, I believe. I wondered how they were able to actually come up with the precise link to COVID, and it sounds like the temporal relationship is an important marker there. Are there differences between what's being described in the literature, obviously still evolving, and the Montreal experience?
Yes, our cases here, in the literature, one thing that is striking is that a lot of those kids have GI symptoms. And that's not a feature we usually see with Kawasaki disease. Like, we can see that, but it's not something that's really like a major feature. And a lot of those kids in the first Lancet study and also in the subsequent studies, those are observational studies. So there's one cohort of 10 patients from Bergamo in Italy that's being published also in the Lancet. And there's also there's a French cohort from Necker Hospital that's in preprint. But they're described too. So the kids from those 3 observational studies had a lot of GI symptoms. And here in Montreal, we didn't see that often. The other thing is that the kids that we're seeing, they don't appear to be as severe as the cases that have been described. So we only had 2 cases. Well, I should say 2 suspected cases, because we're still not sure, as I said, if there's a link or a correlation, that went to the ICU.
Is there a clear link that you have identified or that is available in the literature between the pathophysiology of COVID that overlaps with the hyperinflammatory symptoms that are similar: COVID, sepsis, HLH, like all the things under the PIMS umbrella? Do we have a reason why COVID is setting these off in particular?
No, not that I'm aware of. And I think that here we're dealing with probably something different than what we're seeing in the adults, where they have this hyperinflammatory syndrome while they have the active infection with the COVID. And here the kids seem to have possibly had the infection, but now it's kind of resolving, as I said. So this is really something very interesting and that we're going to study more.
So pointing to the adult literature, I think there's obviously a huge push to figure out what the appropriate treatment is. How are you treating these young patients?
So I'd say it really depends on the clinical picture. If they fulfill the criteria of the Kawasaki, then we're just treating as Kawasaki disease. So with IVIG and aspirin, so that's the mainstay of the treatment. In Kawasaki disease, we can use steroids, and it appears in the different studies that those kids need a little bit more of steroids than what we usually are giving, either because they're more severe again. It seems that they present more with shock-like symptoms, or with macrophage activation syndrome also. If the cases look more like the toxic shock syndrome, then IVIG could be used. And if there's really this hyperinflammatory or cytokine storm, I am aware of the use of either anakinra or tocilizumab. But I do not have a personal experience with those medications, but I know that they've been used for the treatment of those kids.
Okay, that's interesting. I think there was certainly an early emphasis on trying to figure out if tocilizumab was an effective agent for adult patients. Yes. Maybe some evidence in these pediatric patients as well. Is there any clue in the literature as to why it's happening to some children and not others? I think we can assume many children are exposed to the virus. Why are some of them developing these unusual symptoms?
That's, again, an excellent question. I'd say it seems that the epidemiology of the PIMS, or this new disease that we're seeing, is a little bit different than from the Kawasaki. So, for example, one thing that is quite striking and interesting is that this increase in cases has not been reported in Asia. It's been reported in France, in UK, and now here we think we're starting to see those cases, but not in Asia. One other thing is that usually Kawasaki disease is more has a preponderance in Asian kids, and here we don't see that. We see some of the observational studies that it was more Afro-American descendants kids, though it seems a little bit different. But otherwise than that, we do not have clues to what could start this disease in some kids. And again, the other thing is that most of those kids had no comorbidities, and so they were like normal kids with no health problem. So that's definitely something we're going to study.
Is it fair to say that this is still a rare phenomenon in pediatric patients? This is not something that you're admitting constantly to hospital?
No, it's still very rare. I saw some numbers in different studies, like maybe 0.1%. Well, this is still to be determined, but it's a very rare complication. And again, we're still not sure if there's a true link or causality with the COVID-19.
What do you think we need to worry about going forward with this group of patients? Is it the concerns are by phenotype? So if you had a Kawasaki's presentation, you worry about the same coronary artery aneurysm disease going forward? Or are there other considerations that you're worried about in the future for these kids affected by the PIMS group of diseases?
Yeah, that's a hard question to answer because this disease is being described only 6 to 7 weeks ago. So in terms of long-term follow-up, we don't have yet. But it looks like there's a difference when they first present, as I say, in terms of maybe more severe presentation, shock, macrophage activation syndrome. So those signs we need to be very aware of. Also, maybe a little bit more of myocardial involvement. So usually in Kawasaki, we can see the aneurysm. We can see the myocarditis, but it seems to be a little bit more preponderant in those kids. In terms of long-term follow-up, we'll see. For the moment, we don't know is there any ongoing effect on the arts, or that has to be followed.
If we do bump into these cases, is there any registries that we should be trying to contact or enroll patients in, or how do we kind of contribute to the ongoing study of this? So
there are different registries in Canada. We have the surveillance program from the Canadian Paediatric Society, so the CPSP. So that's one program that you can enroll a patient or declare cases that you've seen. And they actually have criteria that have been established in terms of diagnostic.
You know, I do adult rheumatology out here, but if the overlap of patients may be a bit older in the patients experiencing Kawasaki disease in the available literature, maybe even the adult rheumatologist should be paying attention and looking out for any syndromes that look unusually like what we recall being taught by our pediatric rheumatology teachers for Kawasaki or similar.
Yeah, certainly. The CDC criteria, for example, they state that it's a multi-system inflammatory syndrome in, I would not say kids, but person below 21 years of age. So, and some, the WHO, it's below 19 years of age. So, like they're including a little bit older kids or adult, I would say. So certainly that's something to be aware of. And definitely we, in the different like observational studies, they're showing that the kids are a little bit more older than the kids we're seeing with Kawasaki disease. So usually we see kids more below 5 years of age, and there are cases describe older kids.
So even an adult rheumatologist, we all have to stay vigilant too. Marie-Paule, are there any specific criteria we should be using to define these cases? So
there are different societies who establish criteria. So the WHO, for example, the CDC. The one we're using are the one from the CPSP, so the Canadian Pediatric Surveillance Program. And so they talk about any new patient less than 18 years of age who meets the following case definition. So they had to be hospitalized with a pediatric inflammatory multisystem syndrome, so the PIMS, or Kawasaki, that appears to be temporarily associated with the COVID-19. And so they define it as a persistent fever, and so they are talking about 3 days of fever or more, and elevated inflammatory markers, so either CRP or ESR or ferritin. And they have to have one or both of the following, so either features of Kawasaki disease, that could be complete or incomplete, or toxic shock syndrome, that could be typical or atypical. And obviously no alternative etiology to explain the clinical presentation. One thing that is important to note is that patients should be reported regardless of the SARS-CoV-2 status. So those are criteria that I find useful also to kind of visualize what kind of what's the spectrum of the disease I was talking about.
And the temporal relationship that you mentioned there, temporal to the testing positive for COVID, or temporal to a syndrome that sounds like it could have been COVID, like upper respiratory tract infection, diarrheal illness?
No, actually, most of the kids that are diagnosed with PIMS had no symptoms of the COVID. So when they talk about temporally associated, it's more about epidemic or a pandemic that is occurring.
Oh, that we are in a pandemic.
Yes,
That's
yes,
the temporal
yes,
relationship.
yes.
So that means that it's a pretty wide net. Basically, most children or all children presenting with the syndromes you've described should probably be considered for entry or referral to the cohort.
At least consider, for sure. And the clinician should consider this disease in the differential diagnosis.
That's really interesting. It makes things so challenging for you guys. Marie-Paule, thank you so much for chatting with us and being on the podcast today.
Thanks to you, Daniel.
That's it for this episode of Around the Room, the Canadian Rheumatology Association podcast. We are produced by David McGuffin, Dr. Dax Rumsey, Kevin Bajnoth, and Aaron Fontwell. We would like to give a special thanks to Dr. Dania Bassodan for her generous help with the background research for this episode. We would also like to thank the Communications Committee and the staff of the CRA for all their hard work. We are supported by funding from Scotiabank, the Canadian Medical Association, and MD Financial Management. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening. Until next time.